I'm going to talk today about extradural spinal infections. And most of the talk is going to be about pyogenic infections, and we'll talk about osteomyelitis discitis, also called spondylodiscitis, epidural abscess. We'll talk a little bit about septic facet-arthritis, and then I'll talk about mycobacterial infections, osteomyelitis. Mycobacterial infections really don't cause much of a discitis, but osteomyelitis and psoas abscess. And then at the end, I'll touch briefly on a few stranger things. Our first case, a 61-year-old man previously treated with radiation therapy for head and neck cancer, and he came in with neck pain and low back pain and upper extremity weakness. So initially he had MRI of the cervical and lumbar spine. So here's a cervical MRI. We have T2 weighted images on the left, STIR in the middle, and non-contrast T1 on the right. First thing you may notice, the upper four cervical vertebrae are T1 bright, and that's due to the previous radiation therapy. But in addition, you'll see that he has severe spinal stenosis, secondary to degenerative changes, a little bit of a signal in the cord, and the surgeon felt that the cervical spondylosis with myelopathy was causing his symptoms. As I said, he also had a lumbar MRI, so this was his lumbar MRI when he initially came in, and we can see T2. STIR on the left, T1 pre-contrast and T1 post-contrast. Was not too remarkable. The L5S1 disc does have a little bit of bright signal in it, but we weren't too concerned about it. Nothing, no enhancement. So we just had some degenerative disc disease at L5S1 and not much else. So 4 weeks post-op, he was recovering from his neck surgery, but he came back to the office and said his low back pain was worse than it was before. So at that point, he had a follow-up lumbar MRI, and here we can see on the STIR images a number of findings. Bright signal within the disc. We have abnormal bone marrow signal in the L5 and S1 vertebrae. On the T1 images, so we can see, we can hardly see the end plates at all. They're very indistinct here, as well as the abnormal bone marrow signal. We also see some prevertebral soft tissue swelling. We can see that also on the STIR, the prevertebral soft tissues, and the prevertebral soft tissues enhanced with contrast. And now there's also some epidural soft tissue thickening and enhancement. So these are typical findings of spondylodiscitis. Disc biopsy cultures were negative, but his symptoms resolved rapidly with antibiotic therapy. So let's talk about the findings for pyogenic osteomyelitis and discitis. Most of the time, these infections start are caused by a bacteremia from an infection somewhere else, whether it's skin, GI tract, GU, lung, endocarditis, anything. The bacteremia lodges adjacent to the vertebral end plate. The disc is avascular, but the infection tends to lodge adjacent to the end plate and starts up infection, which then extends rapidly to the disc. The second most common mechanism is direct inoculation, either from trauma, surgery, discography, epidural catheter. And the third possible way you can get this is starting off as a paraspinal soft tissue infection that eventually involves the spine. So what do we see? So a number of findings are typical. T2 bright signal on the disc is a good finding. Unfortunately, sometimes we'll see T2 bright signal in a degenerated disc. But if you see it, you certainly need to be concerned about infection. Indistinct end plates, I think that's best evaluated on the non-contrast T1, where the end plates are very indistinct, partly because of adjacent bone marrow edema. The adjacent bone marrow edema typically will enhance with contrast, so it's inflammation in that bone marrow, bright on the STIR, dark on T1, enhancing with contrast. Again, unfortunately, the bone marrow changes from degenerative disc disease can also enhance with contrast, so the contrast enhancement in the bone marrow is not specific for infection. One difference is that can sometimes be helpful with degenerative disease. The bone marrow changes tend to have a sharp interface with the normal bone marrow, whereas with infection, the bone marrow inflammatory changes, the bone marrow edema, tends to have a somewhat indistinct interface with the normal bone marrow, and often goes all the way to the edge of the bone. As you can see in this case, often goes all the way to the end plate away from the disc. The most reliable findings to differentiate infection from degenerative disease is the prevertebral and epidural soft tissues. So this prevertebral soft tissue thickening and enhancement, as well as the epidural soft tissue thickening enhancement. These are generally not seen with degenerative disc disease, so they're probably the best findings to help differentiate degenerative disc disease from discitis. Blood cultures are positive in about half of the cases. Unfortunately, the disc and bone biopsies are only positive in about 60% of the cases, so a negative biopsy certainly does not rule out infection. The labs can sometimes be helpful. The SED rate and CRP are virtually always elevated with spondylodiscitis. So this is more helpful if the ESR and CRP are normal. That almost rules out a pyogenic infection. When they're elevated, unfortunately, those markers are very nonspecific, but they are almost always elevated with discitis osteomyelitis. Sometimes we have plain films. You can see plain film findings with spondylodiscitis. Note the normal end plate here, a little bit higher density than the marrow signal at L5S1. Same thing, the end plate is indistinct here, so you don't see that just nice distinct end plate. There's some sclerosis in the adjacent vertebra. Hard to see. There's probably an erosion here. It's a little hard to see it. CT is a little bit easier. You can see the erosions nicely. Very irregular end plate compared to the normal end plate over here. Sclerotic changes. These are reactive changes in the adjacent bone marrow. Okay, so let's go back to our patient who came in and had the neck surgery. Let's look back at his original lumbar MRI and see if there were some signs of infection that we missed. So this was the midline sagittal image. If we look carefully, maybe there was some soft tissue thickening here. The end plates are pretty, are pretty sharp, so that's okay. There is some T2 bright signal in the disc that we noticed, but again, we can see that with degenerative changes. Now let's look at the images off to the side. So this is off to the side here, and now we do see some prevertebral soft tissue thickening that we didn't appreciate. Let me magnify that. Now it's even a little bit more obvious. So this is an arrow pointing to this prevertebral soft tissue thickening, which enhances with contrast. Now there's a little bit of indistinct end plates over here. It's pretty subtle. Again, some T2 bright signal in the disc. But the most important finding that we missed was this prevertebral soft tissue thickening and enhancement, which if we had seen earlier on, we might have suggested that the patient could have discitis, osteomyelitis there, and that's what initially actually brought him into the doctor, because his actual main complaint was the low back pain. Okay, next 59-year-old woman, low back pain and fever. So it sounds like a good history for infection. The infectious disease specialist saw this patient, was very concerned about infection based on the clinical presentation. When we looked at the MRI, it was not that convincing. So do we see any signs of infection here? One thing we do see is at this L4-5 disc, the disc is maybe slightly bright on the stir image. Also, we don't see this dark area that we see in the center of these other discs. So this dark area is called the intranuclear cleft, and most of the time we'll see that in a normal disc. With infection, that intranuclear cleft is lost, so we do, the fact that we don't see that intranuclear cleft at least should raise the possibility that maybe we're dealing with infection here. But it's, again, it's not a very specific sign. Prevertebral soft tissues, not very impressive. Maybe there's a little bit of enhancement in the prevertebral soft tissues. Not totally convincing. Epidural soft tissues, again, not very convincing. Could there be something here? Maybe. So we got a follow-up. Let's see. This is 8 days later, and now we see a very nicely well-defined here epidural abscess. So epidural abscess here. Prevertebral soft tissues thickening and enhancement. The end plates are now a little bit indistinct. So look at the end plate here. We don't see it sharply. A little bit of bone marrow edema now, and enhancement. So now we're dealing with a clear case of discitis osteomyelitis. Next patient, the history was MSSA bacteremia and low back pain, and when they come in with that history, virtually always they're going to have discitis. Once you have a history of bacteremia and low back pain, the probability of a spondylodiscitis is quite high. So we got a lumbar MRI. Yeah, unfortunately, the patient had really bad scoliosis, which made it very difficult to evaluate. So we looked at the spine. And is there infection here? We looked at the L3-4 disc. It is a little bit bright over here, but the prevertebral soft tissues looked okay. L4-5 disc, there is a little bright signal on a disc again here. We don't see anything in the prevertebral soft tissues. The bone marrow, nothing obvious. The end plates looked okay, so not clear cut. We looked then at the more lateral images, and I have the arrow on the psoas muscle, and we have a stir and a post-contrast T1, and we can see edema in the psoas muscle here, and enhancement. So this is edema and enhancement in the psoas muscles. And on the axial images, the arrows again point to the edema and enhancement in the psoas muscles. And this can be an early sign of infection. This was a follow-up 6 days later. And now at L4-5, this is the T2 weighted. We see a little bit more signal on the disc. This is actually the stir image. There's more bone marrow edema here on the T1 at L4-5. The end plates are now indistinct. we see some enhancement in the prevertebral soft tissues now, and also a little bit of epidural abscess that's developed. So 6 days later, there's obvious signs of discitis osteomyelitis that were very subtle on the initial study. Once the imaging SOA sign was written up a few years ago in AJNR. This is also a helpful sign in early infection. High signal intensity in the psoas muscle is another early sign of lumbar discitis osteomyelitis. The next patient had a lot of previous spine surgery and came back to his spine surgeon continuing to have low back pain, and the surgeon tried to figure out what other kind of operation he could do here, because it looks like he's had a lot already done. He did notice that somehow nobody put a spacer in the L5S1 disc, so he thought, well, maybe we'll go ahead and do another operation and put a spacer in there. There also was some lucency around the screws here, so the L5S1 probably hadn't fused. So the patient underwent a anterior discectomy and fusion, and so 3 months after his ALIF, anterior lumbar interbody fusion, he came back with worsening back pain. So now this was his MRI. There's a lot of artifact from the hardware, but maybe this is best seen on the non-contrast T1. There was a lot of prevertebral soft tissue thickening as well as epidural soft tissue thickening. Post-contrast, this enhances with contrast. I know there is a lot of abnormal bone marrow signal, but you can see this just after you can see the abnormal bone marrow signal just from the surgery. But when we saw this prevertebral and epidural soft tissue thickening, we're very concerned about infection. The infectious disease specialist who saw the patient felt that clinically the patient didn't seem to have infection, but we were still pretty concerned about the imaging. This patient had 2 disc biopsies, both of them were negative, and of course, as I said, they were only about, the disc biopsies only positive about 60% of the time, but he had 2 negative biopsies. The infectious disease doctor really did not think he had infection, and decided not to treat him with antibiotics. So this patient did not get antibiotics and improved without any treatment. 9 months later, had a follow-up MRI. This is a T1. The bone marrow signal is now normal. The prevertebral soft tissue thickening that was there before has gone away. On the STIR, again, there's no more bone marrow signal, no prevertebral soft tissue thickening. So everything resolved. So this one was not a discitis osteomyelitis, and most likely the soft tissue inflammatory changes were secondary to BMP, bone morphogenic protein, that the spine surgeons will often used to increase the rate of fusion, and this can sometimes cause a pretty significant soft tissue inflammatory reaction. Sometimes in the cervical spine it can cause dysphagia because of compression of the esophagus, but you can get a fairly impressive soft tissue reaction that can look like a discitis osteomyelitis. Next patient is a 55-year-old man, neck and shoulder pain after a fall, came into the ED. He had a cervical spine CT to rule out fracture. No fracture was seen, but if you look carefully, the disc is very narrowed here. The end plates are irregular. This was at the time thought to be just a degenerative disease. Looking at the soft tissue windows, there is thickening of the prevertebral soft tissues. Maybe something epidural here. Hard to tell as a non-contrast CT. But he was sent home. A couple of days later, he came back and had this MRI. And now we see extensive discitis, osteomyelitis in the cervical spine, a lot of prevertebral soft tissue swelling, this epidural abscess here, epidural fluid collection with compression of the cord and edema within the spinal cord, and ultimately developed quadriplegia. So we'll talk now about epidural abscess. Most frequently, this is a sequela of osteomyelitis discitis, and in those cases, usually the epidural abscess is anterior, in the anterior epidural space. The other way you can get an epidural abscess is just direct hematogenous seeding of the epidural space, and most of the time, when that happens, the abscess is located in the posterior epidural space. So this is a patient with the posterior epidural abscess, no discitis, osteomyelitis, and I think this patient initially had a pyelonephritis and developed this epidural abscess. So the problem with the epidural abscess is neurologic compromise, and there are two mechanisms. One is direct compression, so direct cord compression. The other mechanism is venous infarction, secondary to venous occlusion. Septic thrombophlebitis can cause venous infarction in the spinal cord. So you can develop severe symptoms even though the degree of cord compression may not be that bad. So these need to be treated quite aggressively. Another patient with epidural abscess is non-contrast scan. We see this, in this case, a posterior epidural abscess. It's a little bit hard to see on the T1 images back over here. But if you look on the T2, you can see the dura. This is the dura here. And we can see above the abscess, you can see fluid in the subarachnoid space over here. And then if you look below the lower down, you can see fluid in the subarachnoid space. But at this level in the mid-thoracic, where there's cord compression, the dura is pressed up against the spinal cord. In this case, the abscess, the infection started in the pelvis. This was a patient who had this pelvic abscess, which spread to the sacrum. We can see osteomyelitis of the sacrum, and then developed a sacral epidural abscess that spread all the way up, and sometimes they can spread all the way up from the lumbar up to the cervical spine through the epidural space. Transverse images, we can see the epidural abscess here in the thoracic spine, and CT. If you only have CT, you can often see these on CT. CT is better if you can do CT. It's better with contrast. So here's the contrast outlining this epidural abscess on CT. 52-year-old man, acute lower extremity weakness, sensory loss, urinary retention, and low-grade fever. Another good history for infection. So here was he came in and had this, our typical rule-out cord compression study. And these were images from the cord compression study, and on the right, these are T2 space images, and you can see in the cervical spine, we can see a normal subarachnoid space, anterior and posterior to the spinal cord. And then when you get into the thoracic region, it looks like the cord is expanded here. Okay, it looks like the cord is expanded. So that we don't see the CSF in front and behind the cord anymore. On the STIR images, there is some increased signal in the cord here. but it doesn't look like there's obvious cord compression. It looks more like the cord is expanded. So does the patient have a primary intramedullary lesion? It was a little bit unclear. So we had the patient come back for contrast. And on the post-contrast images, there is now, we can see this abnormal enhancement both in the posterior and anterior epidural space. So there is abnormal enhancement in the epidural space. On the axial images, this is enhancement in the epidural space lateral to the cord. So the cord itself is flattened from side to side, so it kind of looks wider from front to back. So it looked like it was widened in the AP direction, and that's because it was flattened from side to side. So these are the T2 weighted images. So this is above the epidural inflammation. You can see the cord. You can see the spinal cord here with CSF around it. And then the middle slide where this epidural phlegmon is, the spinal cord is flattened from side to side and expanded from front to back, and then lower down we can see the spinal cord going back to a relatively more normal shape. So one pitfall on looking at sagittal images is you can have cord compression on the sides that makes the spinal cord look fatter from front to back, and without looking at the axial images, you might not appreciate that there's actually cord compression, in this case due to an epidural phlegmon. That patient had positive blood cultures for MSSA and had a follow-up 6 weeks afterward. And now we can see obvious signs of discitis osteomyelitis at T4-5. So the disc is gone here, bone marrow edema and enhancement, even some prevertebral enhancement. So these this patient probably had discitis osteomyelitis initially, although it was not apparent in terms of the disc and bone marrow signal. But 6 weeks later, it was the changes were quite noticeable. And this patient actually, over time, these findings resolved. There was no follow-up 6 months later, still on antibiotics, and now the bone marrow signal is relatively normal here. Actually, on T1, it's actually brighter marrow, more fatty marrow here. There's still some abnormal signal in the disc, but all of the soft tissue changes had resolved. So one thing this points out is that MRI is not very good for following the progression, following the change, the response to treatment for discitis osteomyelitis. So even after successful treatment, changes in the bone marrow can continue to progress for several weeks before they start to resolve. So just because the imaging looks worse doesn't mean the patient is not being adequately treated. It's just not a good way to assess treatment. Especially the bone marrow changes tend to lag very significantly between the clinical improvement. Most of the time, the soft tissue changes will stop. It will not progress once the patient is adequately treated with antibiotics. 57-year-old man, 1 week of low back pain and low-grade fever. STIR and T1 weighted images. On the STIR images, the discs, vertebrae and discs look pretty good. Looks like there's something going on back here. On the T1, you can see normal epidural fat here. Right around here, the epidural fat does not look normal. We don't see that nice bright epidural fat. It's hard to tell what's going on. So whenever dealing with infection, contrast is quite helpful. So these are the post-contrast images, and we see a lot of abnormal enhancement here, loculated fluid collections. I think it's a little easier to see on the transverse images. So at L1, there's an anterior epidural abscess at L3. There's another epidural abscess here. A little bit lower down, there's a posterior epidural abscess. So the extensive epidural abscesses here. Looking back at the sagittal images, when as we said, the discs looked fine here. We didn't see anything in the disc, nothing in the prevertebral soft tissues, but in the posterior soft tissues, there was abnormal signal in the facet joint, and especially in the soft tissues posterior to the facet joint, abnormal stir signal, abnormal enhancement. So this was a case that started as a facet septic arthritis and subsequently developed an epidural abscess. So occasionally epidural abscess can start as a septic facet arthritis. The different patient, septic facet arthritis, and here the key to distinguishing a septic facet joint from a degenerative joint is the soft tissues. So here you can see a little abscess in the soft tissues posterior to the facet joint and a lot of edema. So the soft tissue changes generally will not occur with the degenerative facet arthritis, although the bone marrow changes can be identical. This patient had a laminectomy and discectomy 3 days ago and presented with low back pain, had a lumbar MRI, and we can see this big fluid collection in the posterior epidural space. Here it is on the stir and on the T1. Now, if you notice on the T1, some of this fluid has a bright T1 signal, suggesting subacute hemorrhage. And this was not an epidural abscess. This was a postoperative epidural hematoma. And usually the postoperative abscesses don't develop until a week or two post-op. This was only a few days post-op. Usually in those cases we're dealing with an epidural hematoma. So in the differential for epidural abscess, always remember epidural hematoma. This was the axial image. We see this posterior epidural hematoma at the operative site compressing the thecal sac. This is just a different patient with an epidural hematoma. This is a gradient echo image, so you can see the black, the dark signal around it related to the blood products. This one also has a little bit bright signal on T1. So the signal on T1 and T2 can help distinguish the epidural abscess from hematoma, and of course the clinical presentation. Okay, we'll move on now. This is a 32-year-old man with neck pain and weakness, and had a cervical MRI. And in this case, most of the abnormality is in the vertebral body. So there's stir, hyperintense signal, as well as some vertebral collapse, hypointense on T1, enhances with contrast. There is also enhancing epidural and prevertebral soft tissue thickening. And if this was a patient with a history of cancer, we would certainly be concerned this could be metastasis. The disc actually looks reasonably good here. So this end plate is destroyed here, but the opposite end plate looks pretty good, and the disc space is still pretty well preserved. Here are the axial images. Nicely shows the epidural soft tissue mass as well as the prevertebral soft tissue mass. This was biopsied and turned out to be a case of mycobacterial osteomyelitis. So mycobacterial osteomyelitis usually starts in the anterior vertebral body. It can involve the posterior elements. The key thing here is it spreads beneath the anterior and posterior longitudinal ligaments, as opposed to pyogenic infection, which spreads through the disc. So the mycobacterial infection does not have the proteolytic enzymes to chew up the disc. So the disc tends to be relatively preserved until later in the course of infection, and most of the spread from one vertebra to another is beneath the anterior and posterior longitudinal ligaments. This is a patient with atypical mycobacterial infection. Tuberculosis and atypical mycobacterial infection look pretty much the same. Marked vertebral collapse, so-called gibbous deformity here. And you can see that the disc, although the signal in the disc is a little bit abnormal, the disc space is pretty well preserved here. So considering how much vertebral involvement there is, the disc is still pretty good. We can see some prevertebral soft tissue thickening, as well as, and we can see it nicely on the axials, as well as the epidural soft tissue mass. Here's the CT, nicely showing the severe vertebral collapse and spread to the adjacent vertebrae, but the disc spaces are still reasonably preserved here. So this is a typical feature for mycobacterial osteomyelitis. Another patient, this is also atypical mycobacterial infection. With, in this case, there's on T2, the prevertebral and epidural component was dark signal, and you can see on CT it has calcification in it. And sometimes you can have calcification in these. This patient also has psoas involvement, and you can have calcification in the psoas muscles as well. So this is a patient, again, with atypical mycobacterial infection. Another patient with tuberculosis, big psoas abscesses. These are called cold abscesses, I guess because they don't have the same kind of inflammatory process as you see with a pyogenic infection. But big psoas abscesses are a tip-off that we're maybe dealing with a mycobacterial infection. This was an older man with back pain. Two adjacent vertebrae are involved. Again, anytime we see two adjacent vertebrae involved, we're suspicious that we're dealing with infection. The end plates are a little bit irregular. The disc is somewhat narrowed, but not too bad. We have some prevertebral abscess here, and also some epidural. So we weren't certain if we were dealing here with a pyogenic or a mycobacterial infection. We looked carefully. The patient also had a lot of ascites here, which turned out to be tuberculous peritonitis, and this was a tuberculous discitis osteomyelitis. And I think, again, the helpful sign here is that there is a lot of vertebral body involvement on the CT. You can see partial collapse here, a lot of lucencies in the vertebra, and yet the disc involvement is not as impressive. So this was a tuberculous osteomyelitis. Okay, so finally, we'll move on to a couple of the stranger things. In the case records of the Massachusetts General Hospital that they publish in the New England Journal, over the past 10 years, which of these do you think was the most common cause of osteomyelitis? And of course, in real life, this is probably the least common cause of osteomyelitis. So it's not pyogenic or mycobacterial infection, but it actually, they have a couple of cases of brucellosis. So this we don't see too often. This is one patient has a discitis osteomyelitis at L5S1. You can see a little bit of prevertebral soft tissue thickening, as well as edema in the vertebrae, some bright signal in the disc. This patient had a history of drinking unpasteurized camel's milk, so you can get this from drinking unpasteurized milk. One other patient, this was a woman, and this woman worked in a laboratory where they analyzed the specimens from patients with, or I think it was actually maybe from animals with suspected brucellosis, and she developed this in the lab by getting exposed to a specimen and developed this epidural abscess from brucellosis. So a very rare infection. Apparently, just takes a few of these, a few bugs to cause an infection. So it requires a very small inoculation to cause infection. And the final stranger thing is coccidioidomycosis. This is from AJNR. Coccidioidomycosis is seen in areas where coccidioides is endemic. So southwestern United States does have a lot of coccidioidomycosis, and this can cause a discitis osteomyelitis, which can look either like a pyogenic infection. So if we look at patient A, the disc is there's a lot of disc destruction, prevertebral soft tissue. It looks like a pyogenic discitis. Patient B has areas of vertebral involvement here. At L5S1, the disc is involved, but the vertebral involvement has a very sharp margin, unlike the vertebral involvement with a pyogenic discitis, which tends to have an indistinct margin with a normal marrow. And the third patient, you see very nice spread along the anterolongitudinal ligament. So you have this spread of infection underneath the anterolongitudinal ligament, very typical for mycobacterial infection. So, but this was a coccidioides mycosis. So this can look either like pyogenic or like mycobacterial, or some combination of the two. One more patient with a coccidioidomycosis of the spine, extensive involvement of the vertebrae, as well as the epidural space and the prevertebral soft tissues. Okay, so what have we learned? So I just want to stress a couple of key points. First, if the clinician is concerned about infection, but I'm not too concerned, we'll get a follow-up MRI in 1 to 2 weeks. And usually with pyogenic infection, 1 to 2 weeks is enough time to see a significant change. So we saw this patient at the top, very subtle changes. Here we just saw some loss of the intranuclear cleft, which is not a very specific finding. And then a week later, fairly obvious signs of discitis, osteomyelitis with epidural abscess. So it doesn't take too long for these findings to progress. So if you see progression in a week or two, you're dealing with infection. Similarly, if I'm concerned, but the clinician is not concerned, we get a follow-up MRI in 1 to 2 weeks. Again, if things don't progress, then they're probably just dealing with degenerative disease. If they do progress, then we're dealing with a pyogenic infection. The best way to distinguish infection from degenerative changes is the soft tissues. So the soft tissue thickening and enhancement in the prevertebral and or the epidural soft tissues is the most reliable sign to distinguish degenerative disc changes from infection. Also remember the psoas sign, look for edema in the psoas muscles. And the best way to distinguish pyogenic from mycobacterial infection is that the vertebral body destruction is out of proportion to the involvement of the disc. Thanks very much.